Secretariat here in Geneva. But as per usual, it's my pleasure now to welcome the Director General, Dr. Tedros, for your opening remarks. DG, you have the floor.
Thank you, Tim. Honorable Ministers, Excellencies, dear colleagues and friends, thank you for joining us for this week's Member State briefing. Today, we will be hearing presentations from His Excellency, Dr. Osagie Ihanire, Minister of Health of Nigeria, and His Excellency, Deputy Health Minister of the Kingdom of Saudi Arabia, Dr. Abdullah Asiri. Both ministers will share their experiences and lessons learned from the COVID-19 response. We will also hear presentations on the epidemiological situation from my colleagues, Dr. Maria Bankirkov and Dr. Boris Pavlin. First, let me give you a brief update. Globally, there are now almost 22 million reported cases and almost 776,000 deaths. Despite these mounting numbers, there are signs that countries are now much better prepared to respond to COVID-19. Most countries now have a preparedness and response plan and a risk communication and community engagement plan in place. And all countries now have lab testing capacity. At the same time, we see some worrying gaps. Only about half of countries have a national infection prevention and control program and standards for water, sanitation, and hygiene in all health care facilities. Only 1/3 of countries have a national policy and guidelines on infection prevention and control for long-term care facilities. And only about 1/4 of countries have a health occupational safety plan for healthcare workers. 2/3 of priority countries report that they have postponed at least one vaccination campaign due to the pandemic. As each of your countries works on its own response, I would like to take this opportunity to say that by working together, we're protecting each other. It's natural and right that political leaders want to protect their own people first. But in a global pandemic, none of us are safe until all of us are safe. As I said in Tuesday's press briefing, I'm deeply concerned about the potential for vaccine nationalism to exacerbate both the pandemic and the inequalities of the world. The resolution you adopted at the World Health Assembly in May calls for universal, timely, and equitable access to health products and recognize the role of extensive immunization as a global public good. As new diagnostics, medicines, and vaccines become available, it's critical that countries don't repeat their mistakes early on in the response when some countries hoarded supplies. Since May, WHO has been in extensive discussions to develop a new framework to guide fair and equitable access to diagnostics, therapeutics, and vaccines. As part of the ACT Accelerator, the COVAX Global Vaccines Facility is the critical mechanism for joint procurement and pooling risk across multiple vaccines. This week, I sent a letter to every member state encouraging you to join the COVAX facility. This is not just the right thing to do, it's the smart thing to do. Sharing finite supplies strategically and globally is in each country's national interest. The fastest way to end the pandemic and reopen economies is to start by protecting the highest risk of populations everywhere, rather than the entire populations of just some countries. No one country has access to all the research and development, all the manufacturing capacity, and all the supply chain for all essential medicines and materials. We all need each other. Under the COVAX facility, we propose allocating vaccines in 2 phases. In phase 1, doses will be allocated proportionally to all participating countries simultaneously to reduce overall risk. In phase 2, consideration will be given to countries in relation to threat and vulnerability. Frontline workers in health and social care settings will be prioritized, as well as adults over 65 years old and those others who are most vulnerable. A phase 1 allocation that builds up to 20% of the population would cover most of the at-risk groups. If we don't protect these highest risk people from the virus everywhere, and at the same time, we cannot stabilize health systems and rebuild the global economy. Finally, I would like to update you on the timing of the special session of the Executive Board. In consultation with the EB Chair, Dr. Vardhan, who is joining us again this week, we will convene the EB to discuss the ongoing response and the implementation of the terms of Resolution WHA 73.1. Given the existing schedule of global intergovernmental meetings, such as United Nations General Assembly and the WHO Regional Committee meetings, we have agreed on the earliest possible dates, which are the 5th and 6th October. I am hopeful that the co-chairs of the Independent Panel for Pandemic Preparedness and Response, Her Excellency, former President Sirleaf, and Her Excellency, the Right Honorable former Prime Minister Clark, will update the board during the special session. Next week, we will be presenting the Score for Health Data Technical Package, a one-stop solution to strengthen health information systems worldwide and member states' capacity to generate timely, reliable, and actionable data. But in addition to that, since the every week, every Thursday meeting is for you, any recommendations you have or any suggestions you have on what we should discuss, it will be your take. So please suggest or recommend anything you would like us to discuss on Thursdays, and we will prepare the every Thursday meeting based on your needs and recommendations. Now, please join me in welcoming our presenters from Nigeria and Saudi Arabia. I thank you.
Thank you very much, DG. And as DG just indicated, it's now my pleasure to introduce His Excellency Dr. Osaje Ihare from Nigeria. Your Excellency, you have the floor.
Thank you very much, Mr. Chairman. Thank you very much, Director General, for your words of inspiration. Honorable ministers, colleagues, and friends, it is my honor and privilege to be presenting on behalf of Nigeria today. I have a background. The Federal Republic of Nigeria comprises 36 states and the Federal Capital Territory in nearly 930 square kilometers, with an estimated total population of 200 million persons, the highest in Africa. Now, the responsibility for healthcare is shared between the federal government and the 36 states and the Federal Capital Territory. And Nigeria has a well-established Nigeria Center for Disease Control with a clear mandate on epidemic preparedness and control. And Nigeria was also, at the moment of the outbreak of the 19, dealing with the Lassa fever outbreak, which occurs seasonally around November, December, January, February. Slide 2. Nigeria immediately started multi-stakeholder risk assessment on the 20th of January when news of the COVID-19 outbreak came up. Our principle is that if you are not strong, you better be fast, you better be early. We know that our health system is not the strongest, and the outbreak of this COVID-19 threatened to be a serious challenge to all health systems, as we were to see later on. From the 22nd of January, we began to broadcast updates on the outbreak and began to initiate preventive measures. Now, the Minister of Health, the Ministry of Health, inaugurated an interministerial coordinating committee, bringing in the Minister of Interior, responsible for border security, and also the Ministry of Environment and security agencies. Our first line of defense, of course, was the point of entry at our airports. It was clear that the point of entry, the greatest risk would be through the airport. By the 27th of March, the government decided to create a whole of government response by setting up the Presidential Task Force, PTF, which still operates today, meets twice a week under the chairman of the Secretary to the Government of the Federation, and with 5 ministers and other agencies as members. So focus was immediately placed on training, on infection prevention and control measures, and then commenced the implementation of the COVID-19 action plan, which by then had been drawn up. At the onset, we have 3 functional molecular laboratories for testing COVID-19, and they designated the first set of these treatment centers. Next slide, please. Now, this is the situation, the EPICOP as we have today. We have tested a total of 366,244 persons, confirmed 50,488. Present positivity rate is 13.7. We have had 985 fatalities, relatively low case fatality rate of 2%. Now, at the beginning, we focused a lot on targeted testing of those who are just coming or had a travel history, in order to make the best use of the very limited supplies of test kits we had at that time. Now, the timeline of our response is what you see now, the 7th of January, when the Chinese authorities first confirmed this new virus, up to the 27th, when we confirmed our first coronavirus case in Nigeria, who came in here from Italy, Italian citizen, into Lagos. And on the 28th, when the Nigeria Center for Disease Control, under the Ministry of Health, activated the Level 3 COVID-19 Emergency Operations Center. By the 11th of March, the World Health Organization had declared COVID-19 outbreak pandemic, and we started our own recorded first fatality on the 23rd of March in a patient who had a lot of morbidities. Now, by the 30th of March, the government announced a lockdown in the high burden cities of Lagos and Ogun and the Federal Capital Territory. It is instructive that these areas, Lagos and Ogun on the one hand and FCT, they house the major international airports in the country. And those were the areas of entry of this epidemic into the country. And it is not surprising that the spread focused and spread in these 2 areas. By April, we were seeing evidence of community transmission. And by the 21st, we have developed an integrated national health sector, a COVID-19 pandemic response action plan, which we are still unfolding and augmenting. Now, all 36 states of and the Federal Capital Territory have confirmed cases by now, and nobody is free of it. And by the 22nd of July, we had done over 250,000 tests with 60 testing laboratories, and by the 17th of August, we passed 49,000 cases. Next slide, please. This is our response structure. The response which I spoke about, headed by the Secretary of Government of the Federation, cabinet members, agencies, and then immediately taking the next position of the Federal Ministry of Health, which I head, with all its departments and agencies, and one of the agencies is the Nigeria Center for Disease Control, which operates the Emergency Operations Center. Now, the pillars of response, which you can see, are the 1, 2, 3, 4, 5, 6, 7, 8, which are the pillars with which we respond to the challenge of this disease outbreak. Now, the 36 states have also opened their state health emergency operations centers. Next slide. Now here, the PTF developed a 3-phase restriction, easing, and also enforcing strategy. Phase 1, as you can see, the what we do with land travel, airspace, movement, working hours, because we sent a lot of the staff who are working for government to go home to reduce the activity on the streets and managing workspace to reduce capacity to the low level entertainment activities, gatherings, and schools were closed. These are all the non-pharmaceutical interventions spoke of. And the phase 2, the release, and phase 3 is complete over. We are presently in phase 2. Now, this gives you the capacity as we have it at the moment. We have 64 laboratories, and these exclude 10 private laboratories which function and charge. The remaining 64 do not charge for tests. Only 4 states at present do not have a laboratory, and the positivity rate in this country has dropped from 19.7 to 13.9. Now, we already mentioned the states that have and do not have testing capacity, and the average testing a day has risen from 500 at the very beginning to 3,500 daily. This is actually just about half of the capacity. We have the capacity to take up to 7,000 tests daily. Now, the challenges we have in harmonizing federal to state response, we are dealing with 36 states plus federal capital territory to ensure a national response to coordinate and organize activities. We work with the public frustration over the necessary socioeconomic fallout of restricting movement and travel. We also have issues, of course, with collecting samples from all the areas. The transmission, community transmission, of course, means that we expect the COVID-19 to have in very many rural areas, but it accounts for the low testing result. Now, the economic and the healthcare considerations have to be considered in shaping response. As we protect lives, we are focused on protecting livelihoods, which pose a security threat if they are not addressed and given necessary consideration. Now, finding access to necessary laboratory consumables and also personal protective equipment has been a sort of a challenge, but it has eased of late with the support of partners and agencies that have worked with us, and we are at the moment improving contact tracing and increasing testing capacity. We maintain access to routine health services, which was a challenge at a point when fear and excessive focus on the COVID-19 outbreak reduced the demand and the supply in routine health services because health workers failed to turn up at their place of work. By now, most of them have received training and they have received the confidence to report to work. And patients who were frightened to go to hospital because of fear of getting infected are also now turning up. Now, our achievements in the last, since this outbreak, is that we have been able to strengthen the subnational EOCs through capacity building and providing all the tools for response. We have greatly expanded the human resource capacity and availability to respond to the outbreak at all layers and also at all in all categories, in all pillars across all the states. We have also developed the integrated national health sector COVID response action plan, which we are using to coordinate our response to this outbreak. There's a stronger collaboration with health sector agencies and among them and along with our partners, particularly the UN group. By utilizing data in our response, focusing on risk communication, engaging community leaders, religious leaders and traditional leaders who are the gatekeepers of the communities, and we are improving case management and focusing now on the smaller provinces, which here we call local government areas, and we have a managed and structured easing of restrictions, which is coordinated by the PTF, Presidential Task Force, to avoid overburdening the health system itself. Now, the way forward, now we are capitalizing on increasing testing capacity to reach 2 million tests done by September. as we said, increase the treatment and ICU sites, which was a priority. We have used the opportunity to strengthen the health system, to increase capacity, bed spaces, and abilities, and also stockpile of needed essentials, particularly PPE. And we are supporting the local production of personal protective equipment and other commodities. There's improved compliance with the non-pharmaceutical interventions, wearing of face masks, sanitizing the hands, and also social distancing. Places of worship are either in some states not open, or they're open with very strict limitations. Now, the strategy we have at the moment 11 high burden COVID-19 high burden local government areas, which are provinces, on which we are focusing particular attention, and also creating community case management sites. Now, the mandate of the Presidential Task Force is 6 months, and we've been developing a proper exit strategy for it. And the exit strategy involves preparing the federal ministries, departments, and agencies to provide the support to the state governments and improve leadership and ownership at all levels, and above all, ensure continuity of essential and routine health services. We wish to use the opportunity on behalf of the federal government of Nigeria to thank the World Health Organization and the UN agencies and other development partners, and must mention the support of the Jack Ma Foundation. They were among the first to send us commodities, and in Nigeria here, the Dangote Foundation, we must mention the very strong collaboration and cooperation we have received from the Nigeria private sector, the Bua Foundation, the T.Y. Dajuma Foundation, and the organized private sector, and all the health workers who have been involved in response. And I want to thank you very much, and close by using the words of the Director General, that none of us is safe until all of us are safe, to hold hands and work together. Thank you very much for the opportunity.
Thank you very much, Excellency Ihane from Minister of Health from Nigeria, for your presentation. It's now my pleasure to introduce from Saudi Arabia, His Excellency Deputy Minister from the Ministry of Health Protection, Dr. Mohammed Asiri. Dr. Asiri, you have the floor.
Thank you very much, Your Excellency, Director General of WHO, Your Excellencies, Ministers of Health and delegates. My name is Abdullah Asiri. I'm the Assistant Deputy Minister for Preventive Health at the Ministry of Health, Saudi Arabia. And I will take you through a quick overview of the COVID-19 situation in Saudi Arabia. The first slide is the epidemic curve of laboratory confirmed cases of COVID-19 in Saudi Arabia. We had our first case early in March 2020, and it was a travel-related case, but very soon after that we witnessed an intense community transmission in multiple cities in Saudi Arabia, and the transmission peaked in mid-July, where we had the highest number of daily cases, and then after that slowly the curve was declining. We had a small peak of an increased transmission immediately after the annual festival of Eid al-Adha, where an intense travel between cities and social gatherings took place, and it was expected. But after that, the curve resumed declining, and now we are seeing a growth rate around 0.1 to 0% on the rolling 7 days average of cases. The laboratory confirmed cases of COVID varies between region. We have 13 administrative regions in Saudi Arabia. The highest of transmission is in the eastern region, which happens also to be the first region to confirm COVID cases early in March. However, the distribution or the intensity of transmission varies between regions. We had regions that had peaked in July and then gradually declined, and these are led by the Riyadh and Eastern region, which happen to be the two regions with highest density of population. In smaller regions, we are seeing more of a sustained transmission and recording of cases, but these are not affecting the overall epidemic curve in the country because they are a low density region. The epidemiological characteristics of COVID cases in Saudi Arabia is similar to the global characteristics. We are seeing that the majority of cases are asymptomatic, but in smaller regions we tend to see more of symptomatic cases, in some regions up to 80% in the early outbreak were symptomatic, but now with the expansion of the drive-through testing and the contact tracing, we are seeing less and less of symptomatic cases. Males are the predominant of cases. 67% of all laboratory confirmed cases are males, and we are seeing witnessing an increase in the recovery rates. Now we are well above 90% of cases have met the recovery criteria. Our case fatality rate currently is about 1.1%, which is towards the lower end of what we are seeing globally. The majority of laboratory confirmed cases are between 20 and 59 years of age. More than 2/3 of cases are within this age group. And as we said, that the recovery trend is progressively increasing, and we expect to continue to see recovery rates of more than 90% in the coming few weeks. From the laboratory aspects point of view, we have 51 labs accredited around the country, governmental and non-governmental, to do the polymerase chain reaction. And our daily capacity is 90,000 tests per day, but what we are seeing now is anything between 50 to 65,000 tests being performed daily. The laboratory turnaround time is less than 72 hours in most of the weekdays, and we witnessed that the positivity rate is declining steadily. We had a positivity rate in April and early May well above 30%. Now we are in the vicinity of 2 to 4% positivity rate. We introduced also the serology tests, mainly to aid the epidemiologic investigation, but they are not used to diagnose cases or as an immune certificate. They are used to decide on or help to decide when to lift restrictions, especially in areas that witnessed intense transmission in the beginning of the outbreak. The access of testing is free and it is publicly accessible. We have around 12 mass testing sites, drive-throughs, and again the turnaround time is less than 72 hours. The results are displayed or sent to the people who ask to be tested by SMSs and by application notification through the Ministry of Health application. As mentioned by His Excellency the Minister of Health in Nigeria, the response has to be all government approach. So we have a Supreme Committee that is overseeing the response to COVID-19, headed by His Excellency the Minister of Health, but more than 13 governmental organizations are represented, and social distancing and geofencing is the mainstay of preventive measure that is monitored by this committee. We have introduced 3 mobile applications that are directed towards detecting positive cases directly from the laboratory results without displaying the identifiers for those who are positive, but anybody who's around these individuals in the last 14 days will be alerted that they have been probably in contact with a known case. Also, we introduced a massive health education campaign. A daily press release and briefing is held by the Assistant Deputy Minister, where the epidemiological situation is discussed and the new cases and new deaths and hospital occupancies, intensive care unit occupancy is displayed publicly to everybody. As you know, that the Hajj this year was a success, and it was meticulously planned for, and people were allowed to perform their duties freely while maintaining the social distancing and all the preventive measures that have been approved by the Supreme Committee. And day before yesterday, the 2 weeks observation period was completed for all those who participated in Hajj in 2020, and also for people who served the Hajjis or the pilgrims. And I'm very grateful to God to say that the Hajj was declared to be free of COVID-19 this year. All other measures are monitored by the Supreme Committee, and as you have seen in the media, the reports of social distancing and compliance to masking has been in the range of 80 to 90%, with the highest rate being in the religious sites. The last slide talks about the ongoing research in Saudi Arabia. We are participating in 2 phase 3 clinical trials for COVID vaccine. One is the viral vector virus, and the other one is in live attenuated virus. We are also contributing in the Solidarity trial, the global trial for therapeutics on COVID-19. And also we are a member of the Access to COVID Tool Accelerator, a founding member, and we are proud to be part of the council that is being formed now for the ACTA. Also, we have launched the National COVID-19 Vaccination Strategy, and it's being now approved by the Supreme Committee, where the quantities and the populations targeted by the vaccine will be defined and approved. With this, I thank you very much for listening, and I would also thank the Director General and Your Excellencies for sharing this experience and giving us the chance to be with you today. Thank you.
Thank you very much, Dr. Abdullah Asiri from Saudi Arabia. Your Excellency, very much appreciate and welcome that presentation. Before we go to questions and answers, I'd now like to take the opportunity to welcome technical staff here from the Secretariat to provide an epidemiological and technical update on the COVID-19 situation. I first give the floor to Dr. Boris Pavlin. Boris, you have the floor.
Thank you very much. Good morning. Do we have the slides? Great, thank you. So as you are all probably aware, the global overall risk of this pandemic remains very high. And in this slide, we explain a few of the reasons for that. In terms of the impact on human health, the COVID-19 pandemic continues to produce severe illness in about 20% of patients, with an overall case fatality rate thus far of around 4%, or infection fatality rate, meaning those, not only those who are identified as cases, but anyone infected, of about 0.6%. Though this remains highly variable across different countries and different subpopulations. Most notably, there's an increased risk of severe disease and death amongst the elderly and those with comorbidities. And other populations remain vulnerable, such as indigenous groups and those in closed settings. We've also heard about the interruption in routine services such as vaccination and other control programs, which may contribute to overall increased morbidity and mortality. As far as likelihood of spread, obviously this outbreak has spread across the globe, and it is accelerating in many places. And there continues to be a risk of spread to susceptible populations as public health and social measures are loosened in order to try to reopen economies and life. In terms of areas of particular concern are the ongoing infections in healthcare workers throughout the world, largely due to continued shortages in personal protective equipment. And we also anticipate that there will be increased spread amongst other highly vulnerable populations, such as those in humanitarian settings, where we have begun to see the impact, but we are concerned that it could increase. And we are still not, this is a very new virus, and we are still very much learning about the ways in which it transmits and the different factors affecting transmission, which is one of the reasons why it remains a very high risk. And obviously, there continue to be challenges in terms of control in the realm of shortages of staff and equipment, high caseloads that may be overwhelming healthcare systems and pushing out services for other illnesses. The point made by the Director General about the variable implementation of response, and that unless we work together, the differences in implementation put other countries at risk. And of course, at the same time, we all recognize that severely stringent public health and social measures are not sustainable across the board for indiscriminately for long periods of time. And so targeting approaches is very much a part of the important response strategy. In terms of the global situation, the Director General has already spoken about the general numbers. You can see on the left the epidemic curve with the different colored of the WHO regions highlighted there, and I will speak about each region in the next slide. But what you can see from the general overall curve is that the number of cases continues to increase, though recently it seems to be slowing a little bit. And then in black, the number of deaths being reported on a daily basis. And perhaps one of the things you'll recognize is that the number of cases is growing faster than the number of deaths, which in some regard probably suggests that testing is increasing, and a broader proportion of the population globally is being tested, and we're improving our case ascertainment abilities, which is a positive step. But there's much more work to be done. On the right-hand side, you see some of the countries that are currently reporting the highest number of cases in the past 24 hours, and I will explain each of these as I explain the regional situations. Thank you. The WHO region of the Americas remains the hardest hit. The number of cases reported in last epidemiologic week remains stable compared to the previous week, with a less than 1% increase in the number of newly confirmed cases. However, during the same period, the number of deaths increased by 13%. The United States of America reported 360,000 plus new cases, which was a 4% decrease from the previous week, but leads the region. The number of deaths reported in Peru increased by 220% in the past epidemiologic week to a total of 25,800, and a cumulative death rate of 784 deaths per million population, which is currently the highest in the region. Reports of COVID-19 cases amongst indigenous persons are increasing across the region, with the reported mortality rate higher in this group compared to non-indigenous persons. In the European region, the number of cases reported has gradually increased in recent weeks. However, there is no substantial change in the number of cases reported this week compared to the previous week. Nevertheless, a number of countries in the region are showing a resurgence in cases, including reported in meat processing and packaging facilities in a number of countries, including Belgium, Denmark, and Germany. A total of 2,480 deaths were reported across the region in the past 7 days, which is a 21% decrease from the previous week. However, following a retrospective review process in the United Kingdom, where over 5,000 deaths were deducted, this resulted in a decrease of 2,700 plus deaths in the region overall. Southeast Asia is the second most affected region globally and currently accounts for a respective 26% and 19% of newly reported cases and deaths globally in the past week. The region has seen a steady increase in reported cases and deaths, with a 9% increase in the past 7 days compared to the previous week. India continues to report the majority of cases, accounting for 85% of all confirmed cases in the region as of August 16th, and 92% of cases in the past EPI week. The Maldives has recorded the highest incidence rate globally as cases continue to increase. In the Eastern Mediterranean region, following 5 weeks of decline, a total of 88,700 new cases were reported in the last 7-day period, in the last epidemiologic week, which is a 10% increase. While countries in the Gulf states are reporting a decline in incidence, Iraq, Morocco, occupied Palestinian territory, Lebanon, and Libya are reporting an increase in cases. The number of cases and deaths reported in Pakistan in the past 7 days decreased by 20 and 24% respectively, resulting in the lifting of lockdown restrictions. The African region reported the largest decrease in the number of newly reported cases at 27% and deaths at 21% in the past EPI week, primarily due to a decrease in cases reported in South Africa, Kenya, Algeria, Nigeria, and Ghana. Conversely, Ethiopia reported a 56% and 12% increase in cases and deaths respectively, with more than half of the cases reported in the capital city. Due to the increase in cases, a month-long testing and prevention campaign will be implemented. There are increasing reports of healthcare workers' infections across the region, resulting in an overburdened healthcare system in several countries. The number of cases reported in the Western Pacific region decreased by 5%, as the number of new cases in Japan, Australia, Singapore, and Vietnam decreased. However, the number of deaths reported increased by 90%, mainly due to increases reported in the Philippines, Japan, Vietnam, China, and Australia. On August 11th, New Zealand reported a new locally acquired case after recording 102 days with no community transmission. A total of 52 new cases were reported in the past 7 days, resulting in a temporary lockdown of the northern part of the country. New Zealand is the third country in the region to report a resurgence of cases after a period of little or no known community transmission, besides Australia and Vietnam. I would like to call Your Excellency's attention to the new weekly epidemiological update that WHO has issued its first issue of this week, which highlights some of the types of overviews and regional analyses that I've just presented. It is available online and replaces the daily situation report previously issued. All daily figures are available on the global dashboard listed here. I will now present a series of maps very briefly. This first map shows the cases reported in the past 7 days per million population. And you can see the Americas, as mentioned, is the most affected area. This map demonstrates the percent change in COVID cases over the past epidemiologic week as compared to the previous epidemiologic week, so that you can appreciate where rates of case reporting are increasing, with red being the more affected areas. And I believe you can see for yourselves where these are. And this map demonstrates the percent change in deaths over the same period as compared to the previous week. And as again, the red being the most affected areas. Finally, this map shows the transmission classifications, which are member state determined and range from no cases through sporadic cases, clusters of cases, and community transmission. And you can see that much of the world has, many of the member states throughout the world have declared that they are in community transmission, with the majority of the remaining in clusters of cases. And just to briefly show the age and gender distribution of cases and deaths globally as reported through case report forms from the member states, where you can see that in general, the number of, the percentage of cases between females and males is relatively equal at 47% and 53% respectively, while the percentage of deaths is higher in males. And the age groups are shown there with the number of cases and deaths, and you can see that the largest group affected is the middle ages, while the largest percentage of deaths is in older people. But what's also interesting is if you look on the graphs on the right-hand side, and you focus in particularly on the yellow color, you will see which represents 25 to 64-year-olds. You can see the growing proportion of this relatively younger population over time, both in terms of cases and deaths. Finally, I just wish to draw attention to the fact that WHO has recently issued revised surveillance guidance, which includes modifications to the case definitions, particularly probable cases, and also stresses the importance of reporting weekly aggregate data by the member states to WHO on a number of key variables, cases and deaths, both confirmed and probable, and age and sex breakdown, so that we can continue to monitor the trends globally and by country, and including a formal request for reporting of infections in healthcare workers, and finally to continue reporting transmission classification. With that, I thank you very much, and I hand the floor over to my colleague, Dr. Maria van Kerkhove.
Thanks, Boris. So I will just go through a few slides giving you an update on some of the health operations and technical aspects of the response. And so just to remind you, I'm sure you're well aware that since early January, WHO has been facilitating the sharing of knowledge and information through a number of different avenues. We have convened our technical expert networks in a variety of different areas in clinical management, infection prevention and control, laboratory and diagnostics, contact tracing and surveillance, seroepidemiology, and a number of other partners from all different sectors to help us consolidate evidence and knowledge around this virus and its aspects and the way that it transmits, how we protect people, and consolidating this into advice and guidance for member states. We do have the dedicated member state information sessions, which we are participating in right now, where we can facilitate the sharing of knowledge between each other and how we are all dealing with this pandemic and the response that we have all mounted. We have utilized our strategic and technical advisory group for infectious hazards. This is our STAG-IH, which was established before the pandemic, but it's a group of leaders across the world who help advise WHO and the Health Emergencies Program on infectious hazards. The Director General has also organized consultations with global health leaders from all regions, and these are more informal discussions, but really providing an opportunity to share experiences of where each country is and how they are managing the response as the epidemiology and transmission changes in each of the countries. We have utilized our GORN steering committee meetings, and we have weekly operational partner calls to again exchange information about what is being done on the ground through all of our partners. And we have been publishing technical guidance, reports, scientific briefs, along with a number of different types of communication products for various audiences, training materials on our open WHO platform and other information products so that we get the information out to different member states in terms of governments, in terms of leaders, individuals, different sectors. So we've organized our technical coordination and support mainly virtually because of the pandemic, because we haven't been able to travel, and we've had more than 100 missions to different countries in support of this pandemic. We recently had a mission to China, and this included 2 individuals from WHO who traveled between July 10th and August 2nd. With an objective to work to review the studies that had been conducted so far to understand SARS-CoV-2 virus origin and to identify knowledge gaps and determine the terms of reference for studies and for an international multidisciplinary team that would follow. The outcome of that is that there have been some proposed studies that will be conducted in 2 phases. The first phase are more shorter term studies, which are looking at comprehensive epidemiologic studies, looking at the early cases that were reported and identified in Wuhan, looking at descriptive epidemiology, retrospective analyses, and analytic epidemiology studies, which will be complemented by animal and product and environmental studies. These short-term phase 1 studies will inform the longer-term phase 2 studies, which are guided by the results of those studies and by the science that is learned from them, which will include a number of different types of assessments of looking at epidemiology, virology, serologic assessments in humans and animal populations in specific areas. And so the phase 1 studies will determine what will happen with the phase 2 studies. There are a number of aspects that we are focusing on at the moment in terms of our progress around surveillance, strengthening testing, and strengthening contact tracing. These aspects remain pivotal to our reducing transmission and really bringing the outbreak under control. Looking at surveillance performance indicators so that we can monitor transmission, and some of these indicators will be refined so that we can better track how the virus is moving and how the intensity of transmission is changing. We have been working very hard to improve and increase diagnostic testing at national and subnational levels. And of course, these strategies need to be adapted and strengthened based on the needs of the country. They will also be adapted as new diagnostic tools are becoming available. And I specifically here mention the possibility in the entrance of rapid antigen-based testing, which will enter the market and have entered the market already. There's some very good results that are coming from some of these tests, and they will be very helpful in getting rapid test results back to individuals. We're working hard to support and strengthen GISRIS, which is the influenza network, to ensure that not only COVID testing is happening, but influenza testing is happening around the world, and to have support systems to be able to cope with both influenza and COVID-19 as we enter the flu season in the Northern Hemisphere. And providing additional country support for contact tracing, strengthening risk communication and community engagement, and training. One quick mention of some of the work that we are doing around support for early epidemiologic investigations. This is specifically working with enhanced surveillance activities, focusing on studies and core protocols that can be used to better understand the extent of infection in specific populations. We have 6 core protocols that are currently provided to member states, and we have 2 additional protocols under development for closed settings and for schools. We have 47 countries that have started to implement one or more of these protocols, and these are molecular testing and seroepidemiologic investigations based on population-based serosurveys or healthcare workers or household transmission studies. So we're very grateful for all of the work that you are doing on this. Using these standardized methodologies will really help us to better understand and compare results across countries. We are also providing the molecular and the serologic tests for these studies. We've procured more than 35,000 of these assays, these ELISA assays, and we have tens of thousands more that we will continue to procure and support the implementation of these studies. We're starting to see some of the publications come from that, and we are working very hard through our regional offices and our country offices to make sure that the implementation of the studies will result in reports and publications. So thank you very much for your work on that. We continue to support and to work and to balance the demands of the COVID response with the strategic actions to maintain quality essential health services. This is a major challenge at the country level. We have seen a number of surveys being conducted and showing how essential medical services have been disrupted. We have issued a number of guidance materials and tools to be able to support countries to ensure that these essential essential health services continue, and so that we continue to provide life-saving support to countries for all of the health impacts that each country is dealing with. And then very briefly, just to say that science continues to drive our understanding, and it continues to drive our response to this pandemic. From the beginning, I think in our first member state briefing, we spoke a lot about severity and transmission, and we are still learning about this virus. You hear us say this a lot. We know a lot more than we did 7 months ago. And this is with thanks to all of you for the work that you are doing, with thanks to public health professionals and academics and scientists and individuals who are contributing to the studies. So around the area of severity, there's a lot that we are learning about natural history and disease progression, about the disease that this causes in individuals who have symptoms. We are starting to learn more about the long-term effects of people who have quote-unquote recovered from COVID. Even people with mild disease are still reporting some long-term effects, and we're organizing ourselves. We have case report forms that are out to systematically collect information so that we can better support people who have recovered from this disease. We know quite a lot more about risk factors for severe disease and death, starting with age. We know that advanced age above 60, 70, 80 years old puts an individual at increased risk for severe disease and death. There are underlying conditions such as underlying heart disease, underlying chronic respiratory infections, respiratory disease, obesity, diabetes, and a number of risk factors that put people at increased risk. We also learn, as Boris has mentioned, about indigenous populations and certain race and ethnic groups that have a much higher risk of death. And this pandemic has really highlighted the disparities that we see in a number of vulnerable populations which exist in all countries. There are quite some differences in mortality, as Boris has shown. And if we look at a crude case fatality ratio, which we know there are difficulties and problems in using that estimate, but even if we look at mortality by population, there are some recent estimates of the infection fatality ratio, which is looking at the number of deaths over the number of people who have been infected or estimated to have been infected, and currently we don't know that completely yet. It's currently estimated as an infection fatality ratio of 0.6%, which may not sound like a lot, but it is quite high. It's much higher than pandemic influenza, and we do see a significant increase by age. We can share those papers that have been published. These are in peer-reviewed journals, but there is a significant increase by age of the infection fatality ratio. With regards to transmission, there's a lot of discussion around transmission, of course. What we would like to stress is the importance of not only how this virus is transmitted, but when this virus transmits between someone who is infected, whether they have symptoms or not. We know people without symptoms can transmit this virus. We know that people appear to be most infectious at or around the time that they develop symptoms, which includes just before they develop symptoms. It's 1 to 3 days before they develop symptoms, and early in their illness, which is very different from the SARS virus that emerged in 2003. But what is really, really important right now is where transmission is happening, and the importance of the intensity, the duration, and the context of the exposure that people have. This virus needs close contact between individuals, and the majority of transmission is happening between close contact, through droplets, through contact. We are working hard with researchers, not only epidemiologists and infection prevention and control specialists, but also engineers and architects and aerobiologists to really look at the different contributions of droplet versus airborne and specific settings in which airborne transmission can be possible, to drive that down. The settings in which transmission can be amplified are now well known. We have seen a number of super spreading events in closed settings, in long-term living facilities, in healthcare facilities. We're seeing outbreaks now in many types of entertainment industries like nightclubs. But again, it's where people come together in close proximity to one another, where there happens to be poor ventilation, this virus will transmit. We're learning a lot about the extent of infection as measured by seroepidemiology and the different types of antibody response, whether these are neutralizing antibodies or a T-cell response or a cellular response. We do know that people who are infected with the virus develop an immune response. What we are learning about is how strong that immune response is and for how long that immune response lasts. And this will be very important as we go forward to answer questions around reinfection, to answer questions about the use of a vaccine going forward. But there's very good research that is ongoing, and that research is being shared on a real-time basis with WHO and with partners through our network. And as I mentioned, we have a lot of information now about at-risk groups and underlying conditions as it plays a role in transmission. And we are learning now more and more about transmission among children. As societies are opening up and as schools are opening up and children are going back to school, we're learning that children, of course, can be infected. We knew this from the beginning, from early data from China, although at a much lesser extent than adults, but they can transmit. And there seems to be a very important age breakdown between the youngest children and older children, teenagers, and older adults. So this is important for us as we advise member states. If we look at what we want to do is we want to sharpen our messages around the key things that countries need to be doing and all of us need to be doing, focusing on three major areas of work. And this is not a shift in strategy. This is exactly the strategy that we began with, having to do with suppressing transmission and reducing exposure, having to do with saving lives, reducing mortality and saving lives, and really critically is empowering individuals and communities for action, making sure that individuals know exactly what it is that they can do, empowering individuals with information for action, knowing what they can do to prevent themselves from getting infected and prevent them from passing the virus on to somebody else. There are a number of areas of activity that we are currently focused on, and I'll end with one last slide, and that we are very focused on, and if you've heard the Director General speak in our press conferences, it is not about public health or economies, it needs to be both. So it's very important that as economies open up, they open up safely while using a risk management approach. So our priorities continue to be providing evidence-based guidance, and this is really critical as the science progresses. We are working through our science division, through our partners, rapidly reviewing between 500 and 1,000 papers per day. And harnessing good science into our evidence base and using that to revise as necessary and update as necessary, to strengthen capacities and systems to suppress transmission, to reduce mortality, to empower communities and mitigate the socioeconomic impact, to continue to strengthen surveillance, testing capacity, and contact tracing systems. We have a number of areas of work where we are trying to support this in all countries. Of course, maintaining essential health services and supplies, strengthening community engagement to address the infodemic and mis and disinformation, empowering individuals and communities for action, to advise on the proportionate and risk-based travel measures. We will recently have seen some updated guidance and considerations that we have put out to support countries and decision makers in taking this risk management framework depending on the local context and the context of travel. To really accelerate and drive research to address the unknowns and to improve our technical knowledge. We're really trying to focus on prioritized research that needs to get done and to support countries to do that. To improve diagnostic, vaccine, and therapeutic development with equitable access and allocation. You've heard a lot about the ACT Accelerator, and you will continue to hear more about this. To prepare for the long-term consequences of the pandemic, engaging all sectors. You've seen from all of the member states talking about an all-of-government, all-of-society approach. Into enhancing and sustaining political commitment and leadership for the response activities that are driven by science, driven by data, and driven by experience. And we need national unity and international solidarity. You've heard the Director General say this in every one of his speeches. So I will end Thank you very much.
Thank you very much, Maria and Boris, for that technical update. Now it's the opportunity for member states to raise any questions or comments. Of course, there are questions which can be addressed to the presenters today. They are Saudi Arabia and Nigeria. And we have here in the room not only Boris and Maria, but a range of other technical experts from the Secretariat. So with that, I will ask Fabia this week to support in the moderation of the member state interventions. And please, as per usual practice, raise your hand in the Zoom function and we will take your questions or comments on. So Fabia, over to you. Thank you.
Thank you very much, Chair, and thank you to all of our presenters today. At this stage, I can see that one hand is up, that being from Zambia. So if I may suggest that we proceed with the question from Zambia, and then we come back to the floor to see whether any further questions from member states. Thank you. And with that, Zambia, you have the floor.
Thank you, Chair, for allowing me the opportunity to speak. I'd like to thank the Director General for the updates and the Honorable Ministers of Nigeria and Saudi Arabia for the comprehensive presentations. I would like to learn from Saudi Arabia on their testing capacity, which is impressive, I must say. How are they accessing the test kits and reagents to meet the 50 to 60,000 daily average, as this has been a challenge to my country, Zambia, and indeed many other low and middle income countries? I thank you, Chair.
Thank you very much to Zambia for that question. If we understood correctly, the question was in relation to access to test kits, and it was specifically for Saudi Arabia. If we could kindly inquire whether Dr. Asiri would still be on the line and in a position to respond to this question from Zambia. Thank you, Dr. Asiri.
Yes, thank you very much. I'm still online, and thank you for the question. What we have done is that we have made a huge deal with the three major providers of test kits, namely PCR kits, early in January, and in anticipation that we will need them. This has served its purpose. We were able to secure the amount locally inside the country in early March. So we are still using that contract, and we are hoping that it will carry us on to the end of the pandemic. The testing capacity now is around 90,000 per day. But the actual need from the mass testing sites and from healthcare facilities is rarely above 50 to 55,000 per day. So we have a margin of around 40,000 tests that can be deployed on demand. I hope that answers your question. Thank you.
Thank you very much, Dr. Asiri, Assistant Deputy Minister of Health, for this response to Zambia. I can see that we have another question from the United States. Mr. Smith, you have the floor. Thank you.
Thank you. I have a couple of questions and thank the presenters for the information today. First, the Director General has mentioned and sent a communication about the updated Executive Board special session dates. And I believe what was mentioned was the agenda will be circulated shortly, but if there is any idea of when that will be circulated, and if I understand the proposed items so far, they include an update potentially from the IPPR as well as on the COVID resolution and the actions under that resolution. But if there are other agenda items, it would be good to know what they might be. Second, on the presentation from Maria, you mentioned, and thank you for the information about the origins investigation. Can you provide any sense of when member states might see the terms of reference or who the experts are in the initial or second phases of that investigation? And then third, from previous briefings on the ACT Accelerator and Facilitation Council, I believe we were expecting invitations to go out for that Facilitation Council this week. Is that still the planned schedule? And just maybe an update on that. And then lastly, if anyone knows, or maybe it's only the co-chairs who know, but what the timetable might be for the IPPR co-chairs to designate their panel members. Thank you.
Thank you very much to the US for those questions. Fabio, is there any more hands raised at the moment?
We have one more hand up just now from Canada. Perhaps we can proceed with the question from Canada and then come back to those 4 questions from the US. Canada, you have the floor. Thank you.
Thank you very much for giving me the floor, and thanks very much for all the presentations today. I thought they were excellent, and it's been a very useful update on the epidemiological side as well, so thank you for that. I just had one question, which was whether you'd be able to provide any updates on the latest regarding the IHR Review Committee under Article 50. So if there's any updates on that front, that would be very much appreciated. Thank you.
Thank you, Canada, for this question. We shall now hand back to WHO assigned to respond to these questions. So there were 4 from the United States regarding the EB special session dates, question on the Origins mission and the subsequent phases, a question on the ACT Accelerator schedule, and a question regarding the IPPR. We shall hand back to the chair now. Thank you.
Thank you very much, Fabio, and thank you to Canada and the US for those questions. May I first ask that Maria address the question from the US?
Yes, thank you. Just very briefly, so the terms of reference that were agreed between the pre-mission team and China have been finalized by that team. Right now what we are doing is we are pulling together the potential people who could be part of the mission. We will send out a request through GORM for requests for interest for people who would like to be part of that mission as well. And so as we consolidate that together, we will pull that list together and have a further update once we get those back. Thank you.
Thank you very much, Mr. Chairman. Among the feedback that we received from the member states about the ACT Day Council was that the timing was very, very tight with the target date, the 2nd of September. So we've been looking at potential dates. This has to occur before UNGA, and I think we will be moving it out 1 week to better accommodate the needs of the states involved, as well as the other parties, to the 9th of September. So that has affected the timing and given us a little bit more time in terms of some finalization issues and the issuing of the invitations. So with apologies for any anxiety about unreceived invitations this week, they will be arriving in the subsequent one.
Thank you, Bruce. Now I'd like to move to Canada's questions in relationship to the IHR. I have Dr. Jaude Major. Jaude, you have the floor.
Thank you, team, and thank you, Canada, for this very important question. We are working on establishing the IHR Review Committee as requested by the Assembly resolution, and the Assembly resolution requested or highlighted the mission of the expected IHR Review Committee, which is looking to the functioning of the IHR during the COVID-19 pandemic. We are also looking to potential members who can be in this IHR Review Committee, respecting Article 52 of the IHR. Also working on TORs of the Review Committee, although the mission is clear, but TORs and some potential area for discussion during the IHR Review Committee discussion. And we are also taking experience from previous experiences, working on a mechanism where the IHR Review Committee can consult with member state and with your UN agencies, and also a mechanism with the cooperation, collaboration with the IPPR. All this material will be ready soon for DG's consideration. Merci.
Thank you very much, Joad. Now, coming back to the US's questions, firstly, I'll take the questions in relationship to the special session of the Executive Board. Thank you for those questions. As you rightly mentioned, the focus of the Executive Board special session meeting will be on obviously COVID-19, the response, and the focus primarily will be on the implementation of WHO Resolution 73.1, which is obviously a very broad a resolution with very broad asks to the Secretariat. And as DG mentioned in his remarks, there is a proposal to have the co-chairs of the IPPR attend and provide their update and hear from the Executive Board. We are, in fact, the Director General is in fact speaking with the Executive Board Chair, Dr. Vardhan from India, to finalise that agenda. We are hoping to do that in the coming days and then have the convocation letter circulated to the Executive Board members as soon as possible. With that, I'd now like to ask the DG, could he now take the question in relationship to the IPPR press?
Thank you. So as Smith said from the US, I think the agenda will be around, of course we are discussing, as Tim said, with the board chair, but the agenda will be around the update on the resolution of the Assembly. As you know, the resolution is more than the IPPR alone, so about 9 points actually. So update on the whole Assembly resolution will be one. And the second is the update from the co-chairs of the panel. And I already asked them to present their updates directly to the board session. So I hope the co-chairs will present their updates during the board session. As to the designation of the rest of the panel members by the co-chairs, I know they're working very hard. I think selecting the rest of the the panel members, as you can imagine, will be tough. The number of seats are limited, but we have seen from the nominations made by member states, the nominations are big, and of course it will take time. And what I know is they're doing their best to finish it as soon as possible. But if we have any date from them, we can communicate through the diplomatic channel. We will let you know, and we will get back to them and get you the information.
Thank you very much, DG, and thank you again to those questions from Zambia, US, and Canada. I understand Monaco has their flag raised. We have an opportunity for one last round of questions, so please consider raising your flag, but I would ask Monaco to please take the floor. Carol, you have the floor.
Yes, now it's okay. I was not authorized to unmute my microphone. Good afternoon to everybody. I have different questions. As I am taking the opportunity, as Bruce is present, to know, because last week we received a mail from Gavi saying that we would receive by the end of this week the final letter for expressing our intention or not to participate in the COVAX facility with some documents. It's already Thursday. Do you have some information on when this will be released and sent to the countries? That's one question. Regarding the extraordinary EB, but also the regional committees, we will will enter into discussions for the next program budget. So maybe Tim, that's more for you. When do you think that we will have a first draft? I know that you are very busy, but that would be very helpful, in particular if we want to have a fruitful regional committee. Thanks a lot.
Thank you very much, Carol, for those questions. I'll give the floor to Bruce in the first instance. Thank you.
Thank you very much, Chair. And Ambassador, thank you for the question. So in fact, I've just come from a meeting with Seth Berkley, Richard Hatch, and others involved in the design of the facility and the finalization of the terms of agreement. The goal is still to ensure that we get those terms of agreement out to potentially participating countries this week, countries that have expressed interest. And again, as most of you will be aware, one of the key feedbacks we've gotten as we've worked to co-create the facility is to make sure that there are sufficient mechanisms for all countries to be able to participate. So a lot of work has been ongoing to accommodate that and adapt some of the design elements over the last week or so, and just really credit to all involved with that. So that's meant it's taken a little longer to get the terms of agreement out, but when they come out, and we should be by the end of this week, end of tomorrow, at least it will cover some of those issues that have been raised by member states that would help facilitate their participation going forward.
Thank you very much, Bruce. Carol, if I may, I didn't fully understand your question in relationship to the PBAC and the regional committees. Could I ask you please to repeat that question? Thank you.
Yes, sorry if I was not clear. We will have 14 and 15th of September the Regional Committee for Europe. And among the items that we will have to discuss, there is the future program budget. And this depends on the headquarters. According to what you just said, it won't be at the agenda of the EB, but it's the agenda of the RC. So I would like to know when you will be sharing with us an initial draft, and now that I have again the floor, if we are going to have an information session about that quite soon. Hope I was clear this time.
No, I think it's clear. So we can have the information session, as I said earlier during my speech. The weekly meeting every Thursday is for you. It's your forum. So anything you suggest, we can accommodate during the weekly meeting, during this weekly mission briefing. So you can suggest anything. But if this slot is not enough, we can have additional mission briefings, but we can organize the mission briefings. And we have been discussing with our regional directors on the program budget, and we were exploring different options. So we have been busy with that actually. And the document is in its final stage, and I hope it can be ready for your regional committee meetings. And we will be discussing one more time on this program budget coming Monday, which is next week, so in 4 days. So we hope to provide you that. I don't think the program budget could be discussed though in the special session, because the special session will focus on the resolution, the 9 items, plus even with more focus on the IPPR update, but we can have the program budget during the regular board meeting after the regional committees have deliberated on the document. Thank you.
Thank you very much, Carol, and thank you, DG, for your response there. Fabio, any further hands raised? No. Well, thank you very much again to the member states who have made questions and comments. Bruce, I understand you'd like to make a couple of brief updates on ACT Accelerator more generally, and following that, I will then close the session. Thank you, Bruce. You have the floor.
Thank you very much, Chair. Ladies and gentlemen, just to remind you of two other announcements from the ACT Accelerator. This week, with thanks to Mariangela Sanau, the ADG for Medicines here, who is leading our work on the equitable allocation framework. The team have revised that framework, and that was distributed to all member states on Tuesday evening. You should have received that from governing bodies. And if you haven't, please let us know. We'll ensure you get that. That will be out for 1 week for comments, so we would appreciate comments back by Wednesday, the 26th, by close of business. If we receive them a little earlier, it would be even greater, so that we could then provide some feedback to you next Thursday on direction. As most of you are aware, this is the last round of comment that we expect on the equitable allocation framework as we move to finalize that, at least into the working version that will guide our work in the accelerator across the response over the coming months. And we're hoping to have that finalized by the end of this month, beginning of September. That timeline is essential, of course, because we expect in the coming couple of months to be hearing the readouts on vaccines and key trials, phase 2 and 3 trials, that will affect immediately the application of the framework. The second thing I wanted to remind you of, and Ambassador Monaco alluded to this, there was also a letter from the Director General that went out on the 18th, Tuesday as well, reminding member states of the importance of the COVAX facility, some of the new developments that are ongoing in the design to ensure as many countries as possible can participate, and reminding all that the date for expressions of interest is, of course, the 31st of August. So I just want to remind Tim, our member states, of those couple of developments since we last spoke.
Thank you very much, Bruce. Just one more check, Fabio, that there are no more member states wishing to take the floor. With that, I thank you all very much again, particularly Their Excellencies from Saudi Arabia and Nigeria for your country presentations on the response to COVID, from the Secretariat here for their technical and epidemiological updates. Recalling Director General indicated that next Thursday we will have the release of the score for health data technical package as part of our presentation, and reiterating, as the Director General mentioned, if there are issues you would like addressed during these Thursday sessions, please don't hesitate to reach out to us, and we shall do our best to accommodate those requests in a timely manner. With that, I thank you all very much again and wish you a very good afternoon, evening, and good night, and shall see you next week. Thank you very much.